Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is April 25th, 2024, and I'm your skeptical host, Ken Milne. The title of today's podcast is Bone, Bone, Bone. Tell me what you're gonna do for an IO access location. And our guest skeptic this week is Missy Carter. She is a PA working in an ICU in the Tacoma area and an adjunct faculty member with the Tacoma Community College paramedic program. She is also the local director for the difficult, not the easy airway course, but the difficult airway EMS course at Washington State. Welcome back to the SGEM, Missy.
Thanks so much for having me, Ken. I'm always excited to talk a little nerdy.
Oh, I love talking nerdy with people. But hey, any new life updates? What's going on in the world of Missy?
Well, let's see. So I've converted to the dark side, left emergency medicine and working in the ICU now. That and teaching at TCC keeps me pretty busy. But right now I've been really focused on my kiddo who's a senior in high school. I'm not going to be a kiddo much longer. Getting ready to see her off to college.
College. Wow. Every stage is fun and exciting and anxiety provoking. But just to get back to the medicine part of things, I mean, you've been out in the field, you've been at pre-hospital, you did EMS, you worked in the emergency department, now you're working in the ICU. You've done the whole spectrum of critical care.
Yeah, it's definitely been awesome and humbling to see medicine from so many different perspectives. It really makes me appreciate the work that's done pre-hospital and the ER before the patients come to me in the ICU.
Well, we're going to take you out of the ICU and put you back in the field by giving us a pre-hospital case. What do you got?
Okay, so EMS arrives to the emergency department with a 58-year-old woman who suffered an out-of-hospital cardiac arrest. When the emergency department staff roll her to remove her clothing, her humeral head, IO, dislodges. Later, the medic asks you if she should even bother placing it in the upper extremity or if she should stick with the tried and true tibial plateau.
Well, we've looked at getting access in the pre-hospital setting on the SGEM, and that was episode number 231. And in that episode, we looked at a study comparing intravenous or IV versus interosseous IO access for out-of-hospital cardiac arrest. Now, we need to be careful not to overinterpret that literature because it was a secondary analysis of an observational study which showed an association between decreased favorable neurologic outcomes in the IO group compared to the IV group.
Now, I agree, although thought-provoking, that was kind of weak evidence. So despite that evidence, IO placement in out-of-hospital cardiac arrest has been pretty routine, a procedure that most EMS providers are comfortable with. The classic location for placement has been in the tibial plateau. This is probably because of its ease of use. It's easy to find the landmarks, easy to perform the procedure, and it's distant from other procedures we're performing like defibrillation, CPR, and airway management. Some studies have suggested there may be quicker delivery of medications and fluids through the upper extremity route when compared to the lower extremity route.
So what's the clinical question we're going to try to answer on today's episode?
So what we'd like to know is, does the upper extremity placement of an IO versus the lower extremity placement of an IO really matter in out-of-hospital cardiac arrest?
And what reference will we be discussing today?
We will be looking at Tanner et al., a retrospective comparison of upper and lower extremity interosseous access during out-of-hospital cardiac arrest resuscitation. This is published in Prehospital Emergency Care, February 24.
All right, so let's go through the PCOT. What was the population?
They looked at adults 18 years or older with an out-of-hospital cardiac arrest.
Yeah, and then they excluded anybody who, you've already got IV access, okay, before you put in the IO, so those people are out. Anybody who had a do not resuscitate order, inter-facility transfers, and if it was an EMS witnessed arrest. What was the intervention?
So for the intervention, they used the upper extremity placement. This was 100% the humeral head.
And what did they compare it to?
They compared to lower extremity placement, which was mostly the tibial plateau, almost 98%. The other 2% were femoral.
All right, and let's talk about the outcomes. What was the primary outcome of interest in this study?
The primary outcome was easy to measure. Did they obtain ROSC?
ROSC. All right, and how about the secondary outcomes?
So they looked at survival to hospital discharge and then discharge home as well.
Ooh, there's one really important one I think they're missing, and we'll probably get to that in the nerdy section. Now, you already mentioned this in the actual title of the study, but the type of study this was is a retrospective observational study. So the author's conclusions were, quote, in this large pre-hospital data set, upper extremity IO access was associated with a small increase in the odds of ROSC in comparison to lower extremity IO access. These data support the need for prospective investigation of the ideal IO access site during out-of-hospital cardiac arrest resuscitation. End of quote. All right, let's get through the quality checklist for observational studies. First question, Missy, did they ask a clearly focused question?
Yes.
All right, and did the authors use an appropriate method to answer the question they had?
Yeah, when we're looking for an association, this was a good method.
Yeah, you can do an observational study for associations. You just can't attribute causation. Was the cohort recruited in an acceptable way?
Yeah, this was a retrospective study. It was looking at out-of-hospital cardiac arrests from 2018 to 2022, and it was taken from an annual database.
Yeah, so they just mined the database. That's how they got or recruited people into the cohort. How about the exposure, the IO, upper or lower? Did they accurately measure? And I think it's probably easy to measure that. Where was the IO?
Yeah, I agree. They measured that pretty accurately.
And how about the outcome? Was it accurately measured to minimize bias?
Yes.
And have the authors identified all important confounding factors?
I would say yes. So they went through a multivariable regression. They used the Utstein template. So this considered some important factors such as age, gender, the etiology of the rest. They looked at bystander CPR, the initial rhythm, and EMS response time. They also looked at the type of airway that was used, but they left the EMS agency as a random factor. That brings us to discuss a few potential confounders, such as paramedic experience and some agency factors that could have affected the results. The authors suggested that a more experienced medic and more progressive agencies may use an upper extremity site more frequently. Although I think you could make an argument in the opposite. New grad medics are trained more frequently in upper extremity, so they may be more comfortable using an upper extremity just because of differences in their initial training. Further, it's possible that agencies that are considered progressive could just simply have more distractors to manage during an out-of-hospital cardiac arrest. The retrospective observational style of this study is a clear weakness, but its large sample size adds a lot of strength that many of these other IV and IO location studies really lack.
Wow, you really expanded that question number 6. I mean, it's supposed to be yes, no, unsure, maybe with a little detail, but I think you're chomping at the bit to get to talk nerdy to me.
I may have snuck a little nerd talk in there.
You snuck a little nerdy into the quality checklist. All right, was the follow-up of subjects complete enough?
So, unsure about this one. Of the 155,000 plus patients that were initially included, only about 129,000 had follow-up for the primary outcome. So in the final data set, this was about 17% lost to follow-up. Now, if these patients were included, it may have changed the outcome. This loss was likely due to a hospital database and probably couldn't be controlled for.
Yeah, it's difficult when you see a large loss to follow-up, and sometimes we throw out the number of like 20%, but there's really no hard and fast rule on that. I was taught by a colleague once that if the loss to follow-up is greater than the effect size, you should be more concerned. So when we get to the results section, we'll have to remember what was the actual effect size between the two treatments, upper or lower extremity IO, and that 17% that was lost to follow-up. Question number 8, though, how precise are the results?
They're very precise. So the 95% confidence interval was narrow around that point estimate.
Do you, Missy, believe the results that they had?
Yeah, I believe it.
Now, do you think you can apply their results to your practice population?
Unsure about that.
And do the results of this study fit with other available evidence on IO placements?
So yes and no. So this study was a lot larger than previous studies, and they showed some differing results.
So let's get to the results. This study population, which you mentioned earlier, was like 155,000 something patients. 3/4 of them received lower extremity access, while the other quarter had upper extremity IO access. The median age was 65 years, 61% were male, 81% of the cohort was presumed to have a cardiac etiology, and just over half, 54%, were witnessed arrests. Missy, what was the key result?
Upper extremity IO access was associated with a slightly greater odds of achieving ROSC compared to the lower extremity access.
Yeah, it was a little tiny amount. So they gave an odds ratio. What was it?
This gave us an odds ratio for ROSC of 1.11 with a 95% confidence interval from 1.08 to 1.15.
Yeah, so that's really tight. That's really narrow around that point estimate. Now, for the secondary outcomes, there was 2 secondary outcomes, and they were both statistically significant. What were their actual odds ratios?
Yeah, they were both significant as well. So survival to discharge was 1.18 and survival to discharge home was 1.23.
All right, now let's talk nerdy, okay? You already got to it during the quality checklist. So first thing, we sort of talked a little bit about this already. This was a retrospective observational study, and so this could lead to potential biases for unmeasured confounders. You already went through that a lot. So why don't you get to nerdy point number 2?
All right, nerdy point number 2, comparing upper and lower. So we touched on this earlier, but 76% of the IOs which were placed were performed in the lower extremity, mostly tibial, 2% femoral. The remaining 24% were all humeral. It would be interesting to know what factors determine the insertion site chosen and if that may have affected the outcomes.
Yeah, I'd like to know more information about the decision-making process. Why did you go low when other people went high? Nerdy point number 3, lost to follow-up. Again, we talked about this. 17% of the patients were lost to follow-up. In other words, they didn't have data on them. And given the small effect size in this observational study, this could have biased the results if those patients were systematically different than the ones that were available for analysis. So we need to be cautious about not over-interpreting the result.
Number 4 was a subgroup that definitely stuck out to me. They looked at intubated patients. Those who were intubated and had upper extremity IO did worse than those who were intubated and had lower extremity IO. Now, this could just be an outlier, or possibly it may be that performing multiple complex procedures distracts the team from providing the more meaningful procedures like high-quality CPR and defibrillation.
Yeah, and there was another subgroup that showed a difference, and this was in patients with shorter ischemic time, so the witness arrest and or bystander CPR and shockable rhythms. They had better survival with the upper extremity versus the lower extremity IO placement. A faster rate of an antiarrhythmic, vasopressors, or intravenous fluid administration may or may not lead to an improvement in clinical outcomes. But again, this information is hypothesis generating. Remember, we're talking about an observational study and now a subgroup of an observational study. And if you have enough subgroups, if you slice and dice enough, and you have a large data set, and this is one of the problems with large data, you can find statistical differences with that large data set. Again, if you probe that literature for various subgroups, be really skeptical of subgroup analyses.
All right, last nerdy point, we're going to talk about patient-oriented outcome. So while ROSC and survival are important, a more patient-oriented outcome may have been survival with good neurologic function. We saw this in the Paramedic 2 trial, which was covered in SGEM 238, where survival of out-of-hospital cardiac arrest was better with epi, but not survival with good neurologic outcomes.
Yeah, that's a really important poo. We want to see patient-oriented outcomes, and survival with good neurologic function is really, really important. And in this case, they looked at ROSC, and you can't get neurologic function, good neurologic function, unless you get ROSC, and you can't have good neurologic function unless you survive. But really, we want to see good neurologic function. We want people to be well. Well, that's the nerdy section. Now it's time to comment on the author's conclusions and compare them to the SGEM's conclusions.
So we agree with the author's conclusion about an association between upper extremity IO placement and survival, and also the need for better quality studies to confirm this finding.
Yeah, it'd be nice if they did a prospective randomized control trial, and you may not be able to blind it. You would know whether you went into the humerus or into the tibia, but you could do a clustered randomized design where one paramedic department just is going to go all lower and another paramedic unit is all going to go higher. So you don't get cross contamination and you don't randomize to the individual patient, you randomize to the EMS system. And then you could do a clustered RCT on that. So that would mitigate against some of the blinding issues. All right, so how about an SGEM bottom line?
Upper extremity IO may or may not be superior in patients with out-of-hospital cardiac arrest.
Yeah, we just don't know if it makes a difference if one is superior to the other, or it doesn't really make a difference. It's getting back to the basics of witnessed arrest, high quality CPR, early access to automatic external defibrillators, and having a shockable rhythm. Those are the big things, right? And then maybe the IO placement, maybe really that doesn't make much of a difference. We just don't know. How about resolving the case when you were talking to the medic?
So you tell the medic she made a good choice with her IO selection. Although the evidence is still building about the benefits of upper extremity versus lower, the site may provide a quicker route for medication administration and IV fluids, which may in turn improve your rates of ROSC.
Yeah, so again, when we don't really have good evidence, it's hard to wag a finger at someone and say, oh, you didn't do it right, or you should have done it this way. And I think it's much more supportive to our colleagues to say, hey, it's fine, right? It's fine. You went in the humerus, you went in the tibia. It's okay, right? Because then we're getting down to may give more medication, may be faster, may improve ROSC. That's a lot of mays, which means that's a lot of may nots. All right, so how about the clinical application? Taking this large database study of 150 something thousand patients.
IO insertion remains a valuable tool both in and out of hospital for cardiac arrests. The location in which we place the IO may be clinically relevant, but this procedure, like all advanced procedures, should never detract from our goals of care in cardiac arrest.
And so you really don't have to tell the patient anything because they had a rest, and this was a conversation with the medic. So we're just going to get on to the Keener contest. And last week's winner was Dr. Joseph Reardon, the medical director for the Lawrence Emergency Department. He knew the three categories of human ribs are true ribs, false ribs, and floating ribs. What's the question this week?
Okay, who first described the bone marrow cavity as a non-collapsible vein?
Oh, okay, that's a good question. So if you know the answer to who first described the bone marrow cavity as a, quote, non-collapsible vein, then send an email to the SGEM at gmail.com with Keener in the subject line. The first correct answer will receive a cool skeptical prize. Well, Missy, it was great to work with you again.
Always a pleasure. Thank you so much for having me back.
It's one of my favorite things about FOMED and social media. There's a lot of negative stuff about social media. FOMED, of course, has been just wonderful, but it just brings people together. And we have never met each other in person, but we've been able to have this ongoing sort of virtual relationship about medical education and trying to get patients the best care based on the best evidence for a number of years. So yeah, I really like this.
Agreed. I am definitely a big fan of the foam ed.
So someday in real life, we will get together and maybe do a live version, a together in the same room version podcast together.
Ooh, I'm loving this idea. We need to make it happen.
All right. So until we actually do a recording in real life, can you read the SGEM tagline?
Remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.
Talk to everyone next time.